procedure right now. He is offering a live workshop next year. So if you want to, do hands-on training with him and learn how to do transumbilical placement of silicone, he'll be offering that. The dates of that, I think, are in your welcome program. So thank you so much.
Thank you. And thank the California Academy of Cosmetic Surgery for having me here. Thank for Dr. Gladstone and our past president, Dr. Michael Morrissey. It's a total pleasure and an honor to be here. Thank you, Jacob. He's been instrumental to this procedure. I come from the San Francisco Bay Area and would love to have you over there. I would like every one of you, and I see some of you in the audience that I have trained and in this procedure. And I mean the trans umbilical breast augmentation. I have also talked to one of my meetings. Apparently she's seen over 500 of my videos, and she knew that I could improve her procedure. And she said, I got 3 problems. 1 is bleeding, significant bleeding. 2, I got a problem with rupture of the implants during insertion. And 3, the operating room time is over 3 hours. And I know you can fix it. I don't know. So anyway, I don't have any financial disclosures. I named this procedure the TUBA, or Trans Umbilical Breast Augmentation. And why do I want you guys to learn this procedure? And there is some here in the audience that do it and probably do it better than me. But is because I believe, and it's been demonstrated, that the trans umbilical breast augmentation, and the incision is 1 or 2 centimeters long, is literally 10 times smaller than any 2 inframammary nipple areolar complex or axillary incisions. And there are 2. And number 2, the risk of infection is near 0 with this approach. Is it because it's a tiny incision? Sure, with liposuction, smaller incisions, small risk of infection. But also because an implant pressing against an inframammary or a nipple areolar complex incision causes edge ischemia. Edge ischemia leads to edge necrosis. Edge necrosis leads to infection. So the risk of bleeding, how did I fix this problem? That was an easy cake for me, because and to all of you too, because she wasn't using tumescent anesthesia, and I use a modified technique where I put 2 milligrams of epinephrine. But it's not only me. Other doctors have reproduced this technique with minimal bleeding, obviously. The combination of lack of infection and lack of bleeding at near 0 gives us a capsular contracture rate of less than 0.2%. And this is something that is not just the transumbilical silicone. There's only a few doctors in the world that are doing it. Dr. Wang was the very first one, and I was the second one. And I designed the tunnels also more lateral in order to avoid the central vasculature, so that improved the bleeding. And I also, instead of advancing the implants with instruments, I advance them manually. And I distend the tunnels with a special technique, softly, with hydrodissection and this is reproducible. And so these are over 1,000 cases. Well, look at all the zeros in there. I'm not going to go through it. And this is thanks to Dr. Emma Ryan and Dr. Hayabi, we got published, and they did all the work. I just provided some of the patients, 50% of the patients or so. But I didn't really do much for this, and I'm very thankful. Otherwise, it would not have happened, because I'm not into writing stuff. But here, I think I had 1 tunnel seroma, which wasn't even a seroma. A patient came in, and she had a bump here on the tunnel. I pumped on it, and some mixed blood came out with tumescent. That's it. That was my seroma. And he had an unsatisfactory umbilical scar. Not really a big deal. Small number of cases though. But we should, get better at these. We should teach it. And I'm gonna play the first video.
tumescent anesthesia, modified client solution, and that's very important. And I'm doing the markings now. The modified tumescent anesthesia consists of 1 liter of normal saline, and there is 500 milligrams of lidocaine and 2 milligrams of epinephrine. The measurements here are 5 centimeters at the inframammary fold, 12 centimeters at the costal margins, and 5 centimeters at the level on the umbilicus, and 7 centimeters in between those margins. In other words, 5 centimeters inframammary fold, 12 centimeters costal margin, 7 centimeters in between, and back to 5 centimeters in the inframammary fold. This procedure nicely. So far, this is the same as doing the Trans Umbilical Breast Augmentation with cervical saline implants, right? Now I'm going to go ahead and inflate this test implant with air. You can use saline if you like. I just find it easier to do it with air, and so far I haven't had any problems. Gabriel promised me that we already put 100, so I take the Patino mammary implanter out. And you can see the characteristics of pectoral pocket shape, almond shape of the subpectoral placement. Another thing you want to notice here, that's at 150, is the tension of the pectoralis major muscle. That's 200, and now this is 250. Notice how the implant was inflating a little bit down, so I just push it. Normally I have my assistant here holding this, but we're trying to keep that area. How much we have, Gabby? 250. And now this is 300. Insert the implant, right? And I'm be careful that it doesn't go into the other tunnel, right? So I put my hand over there, they go. And my assistant is done, right? And I have it soaked in triple antibiotic solution, right? And I'm gonna put it, we made this particular incision smaller on her, so I wasn't sure if it was gonna go in, but it went in very nicely, right? And now, so we didn't go all the way. And so now we're gonna go ahead, and that usually helps me over there by lifting the pectoralis major muscle. So we do this manually, right? And how long did that take you guys? Silicone breast implants. We're covering a tattoo over here, but you can see silicone breast implants through the belly button without any scars on the breast, and actually just a tiny incision. We didn't go all the way around.
From the measurements, but that's the size they want. Do you go ahead and do that anyway?
I can answer that question. So there is, I believe, one of the companies have a chart that you can do where you do the exact measurements. And what Dr. Hayabi mentioned, the basic thing is if I see a patient after done all the measurements and they've chosen an implant that's too big for their frame, just take the caliper and I said, look, this is how big your breast width is, and this is how big the implant is, and I put it on top of them. I said, you cannot fit that implant, so you will find a doctor that will do it, but I'm not going to do that. I never ever, like Dr. Hayabi said, tell them what size they should.
Oh, back for more fun. You see that song? Patino de Latino. Very good, very good. We're gonna have fun after a nice meeting. Beautiful, beautiful setting here. Patino de Latino. Patino de Latino. See if we can capture the sunset over here. Look how beautiful this is, you guys. And there's a boat out there in the distance. Let's see if I can zoom in, coming in. Let's see if I can zoom in a little more. There we go. That's a nice boat over there. Beautiful. And the beautiful sunset. Wow, and tomorrow back to what we do best, right? Surgery. To me, there is not much of a difference between working and doing what I love, and then here teaching other surgeons from different parts of the world. This is incredible. So we're very happy and we feel very blessed. What a time. Evening approaching. All beautiful here. And Brooke is over there by the fire already. Yeah. I'm gonna go join her. Mrs. Patino is warming up. Oh, look at you, Brooke. Huh? Nice, huh? Good time, huh? Look at that. This is what a precious view. Great time here.